Taking advantage of the enormous data in the ICUC program of a number of distal radius fractures followed preoperatively, postoperatively with x-rays, CT scans, treated by a single surgeon with a standard Volar approach, and followed for 1 year with outcome. We have approached this by looking at different fracture patterns and trying to assess outcome and management. Many people have thought that there's a number of very complex fractures that may or may not be able to be treated with one approach, that is a Volar locking plate. In this article that's highlighted here, categories of fracture patterns that these authors felt may not be accessible or appropriate to treat with a Volar plate. And these include a dorsal shearing fracture, a radiocarpal fracture dislocations, an impacted dorsal articular piece with an intact or non-displaced volar cortex, an isolated radial styloid fracture, and what we will highlight is massive articular and extra-articular fragmentation and comminution with more than 5 intra-articular fragments as an arbitrary definition. These authors felt these fractures may not be able to be done solely by a Volar approach and a single plate. Looking at the ICUC experience of almost 200 cases, we found 42 cases of dorsal articular impacted fractures with what fulfilled the criteria of massive intra-articular comminution. These were all treated by a single surgeon, single surgical approach, and through an application of a Volar plate. Let me remind you that all of these have been documented from beginning to end. I think it might be reasonable to look at 2 clinical examples. This 70-year-old patient had a fall on an outstretched hand, underlying osteoporosis. Look at the x-rays, which may not seem too concerning, but the value of a CT scan, especially the coronal CT image, shows multiple articular components that are impacted and a dorsal displacement of the carpus with the dorsal fracture fragments. Another view showing this. And what you see on this frontal plane CT is that there's a defect, and that defect is due to impacted comminution. Remember, this is a 70-year-old patient treated with an anterior approach and Volar plate. This is immediate post-op CT scan, and at 28 weeks post-op with a realignment, which is near anatomic. The plate is in a acceptable position described by Sung and colleagues in looking at how this plate reflects its relationship to the perpendicular line of the radius. If this plate extended out here, it would be considered something that is a risk of flexor tendon rupture. If you look at what's called the ICUC score at 203 weeks, we see a score of pain and function. We'll look at another case, here too, in a higher energy trauma in a 20-year-old. Once again, at least 5, if not more, fracture fragments, a distal ulnar styloid fracture, a large radial styloid fracture, and central articular impaction and comminution. In this coronal CT, we see the substantial disruption. The CT scan immediately post-op, the restoration of the sigmoid notch, the restoration of the volar side and the dorsal side, seen once again in the follow-up 25 weeks, and a healed fracture, and the function at 25 weeks. The volar tilt was not restored completely. The placement of the plate is in an acceptable position, and the ICUC functional score was without pain and excellent function. These two cases, neither had a tendon rupture. One had restored to a very normal volar tilt. The plates in both cases were in an acceptable position based upon the criteria of Sung and colleagues as to position and its relationship with risk of tendon transfer. The second patient had no pain and full function, and one had modest discomfort and good function. So all of these fractures in the ICUC score, and in all of the cases now being presented in the ICUC app, are being scored in a very basic way, but a very clear way. One is the functional limitation. Can the patient do everything? Can they do most activities, only certain activities, unable to do most activities, unable to do any? And then pain. And as it turns out, we're faced with many, many different score systems that go through a variety of patient-rated, physician-rated, and may be applicable or attempt to be applicable to many different problems. In reality, what we found is patients relate if they can restore their function and whether or not they have pain. And this is particularly important in the older age patient. We have the opportunity to see functional outcome. And this gives you an idea of the patients, the 42 patients in this series. You see at anywhere between a certain amount of weeks, 27 weeks, 42 weeks, 52 weeks, and so forth. The patients are followed up very carefully and thoroughly. In some cases, we document whether or not a screw had to be removed, whether a plate had to be removed, and that's where we say it's first or second surgery. This is the way to visualize outcome. Keep in mind that one of the strengths of this ICUC experience is that every patient, with few exceptions, can be documented both radiographically, follow up at least a year in clinical basis, and both objective as return to function and subjective as to pain. And if we look at these patients and looking at some of the cases documented, we see that most have no functional limitations and modest amount of pain. I think that this would demonstrate effectively the hypothesis that you can treat these comminuted multiple fragment fractures through one approach, through a volar approach.
With the belief that more transparency in the practice of medicine will enable substantial progress, ICUC is launching a cutting-edge app to improve learning of surgical procedures in orthopedics. The app gathers complete, unchanged and consecutive series of surgical interventions. Independent orthopedic surgeons record the interventions from pre-op to functional result to ensure complete recording, including surgical shortcomings. Download the app from the Apple App Store and access for free to a broad library of orthopedic case studies. Try ICUC app and discover a new learning experience.